And here's okay. تمام. Good morning, everybody, and I'm happy to be seeing you. Many of you I know before, some of you I may not know. Okay, so I chose this topic, fatty acid oxidation disorder, because it's really among the really the most common clinical cases that we see in our clinics in metabolic clinic. Fatty acid oxidation disorder are indeed very, very, very important. Now, this presentation has updates because you need to know the updates. There are updates in treatment, but everybody has to know about them. So I'm going to begin. And this will be how I'm going to go through things. First of all, I'll talk about energy production and fatty acid oxidation and show you the cycle. And then we will move on to the disorders, fatty acid oxidation disorders, and you will understand why they cause illnesses. You will see the clinical phenotypes. I will talk about the diagnosis and treatment and the part of the updates, and then I'm sure we'll have time. I want to give you 2 case examples, and this will be at the very end. So let me introduce you to fatty acid oxidation disorders and tell you that they are among the most common inborn errors of metabolism in infants and children. I don't know about adults. Now, fatty acids, fatty acids are the largest energy reserve, and they supply their energy through beta oxidation. Now, first of all, can you tell me how much calories are in 1 gram of carbs? Anybody know? 1 gram carb will produce how many calories? 1 gram carb. I had you, huh? 20? 4. You are right. What about protein? 1 gram? 4, let's say 4. So, okay, 1 gram fat will produce how much calorie per gram of fat? لا 12 ها؟ لا شاطرة أحسن معي. Okay, yes, 9. So you see, they are the largest energy reserve in our body. They give us a large amount of energy. So now fatty acid beta oxidation now is crucial for the energy needs of heart, skeletal muscles, liver at all times. At all times, our heart, muscles, liver will need the beta oxidation of fat to produce the energy that is required for them. And what about other organs? Well, almost all other organs during fasting and stress. So you see that fatty acid oxidation is very important all the time, but very important for the heart, skeleton, and the liver. Now let's look at energy production. This is important, and please take care. مفيش cursor هنا. Anyway, مفيش cursor. There is no cursor that I can. فين؟ مش شايفة حاجة. طب ولا أنا بحركه بس ما بيتحركش. Okay, so what happens after we eat? Let's say we've had ما أنا جربته ما بيتحركش. خلاص مش Oh yeah, here it's here. So what happens after we eat? Now let's understand here. We eat, glucose and nutrients are in this are being now absorbed and now in the circulation, and glucose now starts to rise a bit. And the first thing that happens is that insulin gets to be secreted. Now, insulin is an anabolic hormone. It's very potent anabolic hormone, and it does what? It induces glucose uptake into the cells and utilization by the cells. All the cells except the brain. The brain does not need insulin for glucose to enter the cells because glucose is very important for the brain. Now, inside the cells, the glucose is used for energy production. Now, whatever excess is stored, it's stored as glycogen in the liver, lipid, and protein. So this is what happen when we eat whatever meal that we take. Now, what happens when we stop eating? Let's say right now, we haven't had breakfast. Maybe we didn't take breakfast, and the last meal was the last dinner. Well, what happened is that the blood sugar is going to start to drop within the normal range. And as it drops, now the first thing that happens is that the insulin has to stop. And this will maintain the blood sugar for a while. But of course, it will start to fall, being used and so on. So what will happen next is we'll have the counter-regulatory hormones, starting with glucagon, epinephrine, and then cortisol and growth hormone. And what maintains our blood sugar properly for all of us now is our glycogenolysis, because glycogen stores are now being depleted and used to maintain the blood sugar within the normal range. Now, midway through glycogenolysis, it doesn't have to totally finish. Midway, we have other things happening, and this is protein breakdown and lipid breakdown. Now, protein breakdown will produce alanine and gluconeogenic amino acids, Now, the fat breakdown will produce glycerol and free fatty acids. I'm sure you know that. Now, these parts, the alanine gluconeogenic amino acids and the glycerol, these are what? They are gluconeogenic substrates. These are very important. So what happens? They will go to the liver and will undergo gluconeogenesis. So as the glycogen stores are getting depleted, protein breakdown, lipid breakdown are now working and produce amino acids and other substrates, glycerol from the fats. And these are gluconeogenic substrates, will produce gluconeogenesis and will extend the glucose not falling down for long periods, very long periods. Now let's look at the free fatty acids. The free fatty acids are very important, and they will go to the tissues and undergo local beta oxidation in the tissue and produce energy in the tissues. And those circulating to the liver will produce beta oxidation in the liver, a very important part here, because beta oxidation in the liver is important. It will produce the energy required for gluconeogenesis to work. And at the time of fasting, of course, this is fasting, the ketone production is being produced in the liver, and ketones here will be an alternative energy source for the brain and other tissues that uses ketone. This is glucose homeostasis in the fasting condition. Now I want you to understand, and let's reflect here. What if we have a patient with a beta oxidation defect? Well, glycogenolysis will be okay. Protein breakdown, fat breakdown will happen, but gluconeogenesis will be impaired because of lack of energy enough. And of course, the ketone production will be impaired. Fasting for long, you'll get hypoglycemia, which will not be helped by presence of ketones. Now, tell me, are you okay or am I going fast? Good. Okay. If any time you need to stop me to ask and let me go back, this is what I love to do. Okay. صباح الخير. Now, another very important slide. Let us look at this. Oh, this is the dependency of tissues on metabolic fuel. Oh, and whatever is circled, this is the dependency of tissue as a metabolic fuel. For example, you will understand now. Let's look at the brain. The brain needs glucose as a primary source for energy. Now, it doesn't use fats, but it can use ketones. That's the brain. The red cells use glucose as the primary energy source. And anyway, the red cells do not last for 3 months. Now, let's go down here. Now, the renal cortex needs the energy from fat as the primary energy source. It can take it from glucose as well and ketones. Now, let's go and look at the important ones. The skeletal muscle. You see, primary energy source. Fats are the primary energy source for the skeletal muscles. Main energy source during rest and mid-intensity exercise. So we are sitting here, we are using our, we are using our fats for energy production. Now, if we exercise a little bit more, you need glucose. See, here you are. As well as the heart. Look at the heart. 90% of the energy demands are derived from fats. You get it? But also the glucose and the ketones can be used. Now as well, the liver, again, the primary energy source is fat. So you see how important for the muscle and the heart and the liver, primary energy source for the heart and the muscle and the liver at all time. And then when during fasting, the other organs will need ketones. Okay? Okay, now you are biochemistry, and even I give this also to our clinical doctors in the clinical in our clinics. And let's understand, because we need to understand this. Now, the fatty acids are made of carbon chains. Now, this is at the end here is a carboxyl group. At the end here is a methyl group. Now, don't worry, this is not going to be complicated. Now, when you look at this fat down here, this fatty acid here, it's a long chain made of 20 carbon. The ones here are, these are the carbons. Okay, and when we want to write something like this up, how do we write this? Do you know? Okay, if you don't know, I'll move on. Good. Okay, so we say C, yes, because this is the carbons. How many carbons? 20. So we say 20, and then we'll put 2 dots here, and then we'll look at what the double bonds, right? Yes. So how many double bonds? Four double bonds. So we'll put 4 double bonds, right? And then we'll put an N, and then we'll ask ourselves, what is the first double bond? The first double bond starts at carbon number 5. So that's how this fatty acid is written. Another way of writing it is 24, and then this triangle, and then these are where the double bonds start, position 5 and 8 and 11 and 14. Actually, when I was doing this, I was very happy because I started to understand certain things, this was a long time ago. So I'm
usually we don't it's long time.
بس
we
لما انا ابتديت افهمها انا ما كنتش فاهمه ايه الستين لكن I was happy to understand, you know. And whenever I show it to my in talks and so on, everybody loves this part. So, and I really, now you see how important it is when I'm talking now. Hold on. So what I just showed you now, C24, it has a name. This is what is known as arachidonic acid. So whenever you have arachidonic acid, it's always going to be written like that, something like that. Okay, now let me show you something else. Now let's do this one. Somebody can do it?
Okay.
You will write C
16.
and C.
Only one.
Where is the bond? No, you don't count this one.
I think nothing.
Yeah. So we'll do this, and there are no double bonds, zero. And this is a famous palmitic acid, very famous palmitic acid. I'm going to use it when I'm talking a little bit later on. Okay, so now if I tell you oleic acid is this one, can you now imagine it? Yes, I can imagine it. C18 carbon, one double starting at 9. Very nice. So now this is a list of certain fatty acids, and now you can look at them and you now know exactly what these numbers mean. So, تمام. Now, chain length wise. Okay, let's look what now. A short chain fatty acid is from 2 to 4 carbons. Medium chain is from 6 to 12. A long chain is from 14 to 20. And these are what I'm talking about today in this talk. They have catabolism, and they go to the mitochondria and produce energy. Now the longer chain, the very long chain, which are more than the 20 carbon atom, these go to the peroxisome, and they have their own metabolic importance. This is not what I'm going to talk about now. I'm going to talk about the first part, the mitochondria and energy. Okay, so let's see what is this. Now let's understand now, this just to get you to understand the landmarks here. This is a cell, and that's a mitochondria, and you know that the mitochondria is a very important energy provider. Do you know how many mitochondria are in the heart? Just give me a number. Because this is one, but I don't want you to understand that's only one in each cell. So anybody can tell me except Sarah. I don't want Sarah to tell me if she knows. Dr. Ayman, do you know?
Three. Maybe three. Or
3,
four.
4?
Because for chambers, maybe for.
Around 800,000 mitochondria. The heart is pumping all the time. يعني ها مش معقول. الهارت عمال يشتغل.
أنا حسب the
One.
chambers.
Okay, that's important to ask questions, because when I ask questions, things will be more important, huh? Okay, very important. There's not only one mitochondria. The more the active the tissue, the more mitochondria are in the cell. Okay, so let's have what we're seeing here. This is the cell, and this is the mitochondria, and this is ATP that comes from the mitochondria. And ATP gets derived from glucose. Here is glucose oxidation producing acetyl-CoA. Acetyl-CoA goes into Krebs cycle and produce what the NADH and FADH to produce ATP. Same thing, there are energy producing amino acids will produce acetyl-CoA. And the fatty acid also will go in here, undergo beta oxidation to produce acetyl-CoA. Now let's talk about the fatty acids. They, of course, they do come, we have stores of fats, and sometimes from the diet, but the fats come into the cell, and they need to go into the mitochondria, where the beta oxidation happens. This is where the beta oxidation cycle is. So let's go into maybe the worst slide, but you will understand it, and we will move on. I have to do it this way. So I'm sorry about this. You will understand it, and it's not that bad. Now let's begin again. Now this is a cell membrane, and this is the mitochondria, which has an outer mitochondrial membrane and an inner mitochondrial membrane. And there are things here in the mitochondrial matrix. طبعا السلايد مش حلوة قوي يعني. My slide is here is beautiful. Your slide is not really showing things. بس معلش بقى. Okay, so let's now have a long chain fat. This is a long chain fat around, let's say C18. Okay, now it needs to go inside the cell, and it does. through a transporter. So now you have this long chain fat inside here. Now the next step that happens is you need to activate this long chain fat. To activate it, you get an acyl-CoA. Acyl-CoA is an active fat, active fatty acid. Acyl-CoA is an active fatty acid. So now it got activated by an enzyme. So now you have this active acyl-CoA, which is the active fat. Now look here. I need this acyl-CoA to go here, to land here. You see it? You see this? I need this black thing here to go here down. And it cannot just go down by itself. It needs the help of some other enzymes. So the acyl-CoA here, what will happen? Now let's go up here and see this is a carnitine transporter, another transporter that transports carnitine inside the cell. So we have inside the cell carnitine, and we have now the active acyl-CoA. Now this enzyme, this is the CPT1, which is located at the outer mitochondrial membrane, will combine the acyl-CoA with the carnitine, forming acyl-carnitine. We have now acyl-carnitine through CPT1 enzyme. Now the acyl-carnitine will translocate into the mitochondria. So this acyl-carnitine up there has now reached the inner here, acyl-carnitine. This one. Got it? Now, okay. Now we have acyl-carnitine. Now I want acyl-CoA and I don't want the carnitine. So there's CPT1, CPT2 will remove the carnitine from the acyl-carnitine, and now we will have what? We will have the acyl-CoA and the carnitine, which will go back again to be recycled. So now I have this active fatty acid now inside the mitochondria, mitochondrial matrix through the carnitine cycle enzyme. So these above things are carnitine cycle enzymes. The ones in the blue up there, the carnitine transporter, CPT1, translocase, and CPT2. Okay, so now at the end we have the acyl-CoA. As soon as it's inside the mitochondria, it will meet Mr. VLCAD, the very famous enzyme, the VLCAD. And then it meets, and after the VLCAD, it meets other three enzymes. There are 4 enzymes in each beta oxidation spiral. These are the beta oxidation enzymes. The important one is the VLCAD and the LCHAD. Now, LCHAD can be genetically a disorder alone, LCHAD, but LCHAD can also have another genetic implications where there are 3 enzymes. So this is called the trifunctional mitochondrial enzyme where it's LCHAD and the other 2. It doesn't matter. Let's just say that the VLCAD and the LCHAD are here, and there are actually 4. Now let's have C18. Now C18 will pass through VLCAD and this one, and LCHAD and this one. And now this cycle will remove what? Will remove 2 carbon atoms from the C18. So now we have 2 carbon atoms less. And now we have it now becomes C16. So now it goes through another cycle. C16 becomes C14. And then C14 becomes C12. And each spiral, we have minus 2 carbons, which will form 1 acetyl-CoA. So each spiral, we will have 1 acetyl-CoA forming, and also something very new, and we have to understand a molecule of NADH or molecules of NADH and FADH2 from here as well, not only acetyl-CoA. Now, once now the carbons are 12, these cannot act. And now the specific enzyme that will act is the medium chain enzyme, also the MCAD and MCHAD and there are 4 as well. So the C12 becomes C10, C8, C6 through the medium chain enzymes. Okay, now it's C6, so now we need the short chain, so C6 becomes C4 and C2, and that's it. So now all the carbons from this long chain have become, each 2 have become one acetyl-CoA, and also giving us some NADH and FADH2. Acetyl-CoA will go into Krebs cycle, where oxalate becomes citrate, and this Krebs cycle is really very important to also now as an update in the pathophysiology of fatty acid oxidation defect. Now the Krebs cycle will move on and to produce the ATP that we need here. I'm not going to talk about the respiratory complexes here. I can do that if you want at the end. But this is where energy is being produced. Big energy coming from fat. Now, at the time of fasting and only in the liver, acetyl-CoA can also go and produce ketones only in the liver at the time of fasting. And of course, ketone is a secondary energy sources for other organs. Now, oh yeah, the liver produces ketone but cannot utilize ketone at all. It gives it to other organs for use. Okay, now having said that, let me just tell you that the medium chain fats do not need the carnitine cycle. They enter immediately, and they will meet the medium chain enzymes for their energy. So they don't need the carnitine cycle, and we use the medium chain for treatment. You know that in fatty acid oxidation. In fact, the long chain fatty acid oxidation, medium chain are used for energy. They bypass the problem here. Okay. I have done the first part, telling you about the beta oxidation, and now we'll move on into the disorder. You will understand now why they cause the illness and go through the clinical phenotypes and so on. So now, as a group, fatty acid oxidation disorders are one of the commonest groups. And here in Kuwait, I think that they are the commonest that we see in our clinics having metabolic decompensations. At least 22 different enzyme defects have been characterized. And for this part in the square here is worldwide. The prevalence is 1 per 10,000 through newborn screening, where VLCAD even worldwide is the commonest discovered. The MCAD is this is the incidence of MCAD in Western countries. I have the results from Kuwait, where over 7-year period from 2015 to 21, the incidence of VLCAD is 1 in 833. So in Kuwait, the commonest fatty acids are the VLCAD, and the next common long chain fats are the LCHAD. Okay? Now, high mortality. They are reported to be of high mortality, as high as 75 to 90%. This is from recent publications. Now, the early onset disease, the clinically early disease, of course, mean severe enzyme deficiency, and they have the least favorable life prognosis. And if you do newborn screening, it's good. Yeah, it's good. It has a positive impact on survival. We can diagnose early, we can start treatment early, but still we need to understand that mortality remains high. There is still a constant risk for metabolic decompensation always for these patients during periods of prolonged fasting and illness. So always we have to worry. When we look at the disorders, there are those that are within the carnitine cycle, and these are the enzymes that I mentioned, and these are the long chain enzymes. LCHAD, I said, can be an isolated LCHAD or part of 3 enzymes in the mitochondrial trifunctional protein enzyme deficiency. Now, let me show you again what I want to say here. Okay. Now, again, this is a summary actually. If we have, let's say, palmitic acid now, palmitic acid is C16, you know that. It has to enter the mitochondria through the carnitine cycle, meaning these enzymes. And now inside the mitochondria, it gets activated to palmityl-CoA, which is active fat. And it meets the 4 enzymes, 1, 2, 3, 4, the 4 enzymes in the beta oxidation spiral. And each cycle will produce FADH2, NADH2, you can see them here. And it produces acetyl-CoA. Right? This is, I'm summarizing. I'm making it simple now, leaving the other one. And now acetyl-CoA will enter Krebs cycle. And Krebs cycle will produce more NADH, FADH2. And they'll give electrons to the respiratory chain and produce ATP. Now in the liver, at time of fasting, ketones are being produced from acetyl-CoA. And let's remember that these enzymes are chain length specific. More than 2 carbon, the long chain work. From 6 to 12, the medium chain enzymes will work. Less than 6, you have the short chain enzyme working. Got it? Tamam. Now, look. Palmitic acid gives a total of 132 ATPs. Let's have a look. I find it really fun. Now look, now from this FADH2 that comes from the beta oxidation cycle, you get 14 ATP. Now from the NADH, you get 21 ATP. And from the acetyl-CoA, you get 80 ATP. So total is what? First of all, let me tell you that in order to activate this fat, you need energy. You need the 2 ATPs from some other source. So the total, if you count them all together, Palmitic acid gives a total of 123 ATP, one molecule of palmitic acid, 123 ATP. But suppose we have an interrupted oxidation. Suppose we have something here, a VLCAD deficiency. Will we get anything from FADH2 here? We'll get 0 ATP. And we'll get a 0 ATP from here. We'll get a 0 ATP from here. What is the total net ATP produced? Actually, there's no product input. It's minus ATP, minus 2 ATP that had been used elsewhere. So you can see the degree of energy crisis that we get when we have fatty acid oxidation defect, right? From something very good to something very bad happening when we don't have this enzyme. That's bad. Okay, now let's move on and look at the pathophysiology. Okay, same slide, same thing. I'm telling you that we have a block here, and when we have a block here, we are not going to have the FADH2, the NADH2. We don't have the acetyl-CoA. Krebs cycle isn't producing enough ATP from its source, and then we have poor ATP production. This is an energy crisis. Okay, remember, I'm telling you that the ATP being produced from fats are very important to drive gluconeogenesis. So if this patient is fasting, where is gluconeogenesis? It's going to be interrupted, and therefore there is disruption of the Krebs cycle, and there will be fasting hypoglycemia that will not be helped by the presence of ketones because there is no acetyl-CoA in the liver enough to produce ketones. So you can see the degree of energy problems from the ATP deficiency, the Krebs cycle dysfunction, the fasting hypoglycemia, which is even non-ketotic. Now, the build-up of toxic acyl-CoA inside the mitochondria is also disruptive for the mitochondrial health, and also it produces encephalopathy, by the way, the accumulation of toxic acyl-CoAs. So this is the updated pathophysiology that happens in long-chain fats or in fatty acid oxidation defects. Here, everything is here. It's an impaired energy production due to impaired ATP production, impaired gluconeogenesis, impaired ketogenesis, tricyclic imbalance because of depletion of the intermediates that happen in this condition with the accumulation of the toxic metabolites, all the pathophysiology lined up for you to see. A very difficult thing, right? Okay, now because of this, the illness is due to energy deficiency, the accumulation of toxic acyl-CoAs, hypoketotic hypoglycemia, but we have to understand that it occurs late and when the patient is fasting. Look here. Now, the encephalopathy, which starts with lethargy, progressing to coma, is from the toxic acyl-CoA that start to build up even before the patient is hypoglycemic. He's not comatose because of the hypoglycemia. He's encephalopathic because of toxicity. The toxic acyl-CoA is building up. Of course, now the lack of energy for the heart. This is cardiomyopathy, heart failure, liver dysfunction, hepatomegaly, the myopathy, and the rhabdomyolysis that happen in this condition. All the clinical picture now is understandable. When you do the biochemistry quickly here, the ALT will be elevated, CPK, the hypoglycemia is hypoketotic. Now the ammonia may be slightly high, lactate may be slightly high. I'm going to go through that a little bit. Now, when you look at the presentation, there are certain, you can just say that these are the presentation. Presenting with a hypoketotic hypoglycemia with the liver encephalopathy. So the patient is encephalopathic with hypoglycemic, hypoketotic, hyperammonemic sometimes because if in severe cases, and this is this phenotype would be triggered by catabolic state. The cardiomyopathy is triggered by a long-standing lack of nutrients properly, and also by catabolic status, which is a cardiomyopathy, dilated or hypertrophic with arrhythmias. Now, the muscle myopathies could be just longer standing, and particularly if exercise-induced myopathy that occurs severe with rhabdomyolysis. Sudden death can happen at night, prolonged fasting resulting in hypoketotic hypoglycemia or a cardiac arrhythmia. Now, let's look at the clinical manifestations. I'm not going to go through them, but I just want to tell you that the onset can be on newborn screening when the patient is asymptomatic, but even at any time during adult life, maybe. missed by newborn screening and he has a mild disorder and then he develops a clinical picture like this. It always have we have always to put this in our mind when we are dealing with these patients. So the clinical picture can present at any age. This is important. This slide just to tell you that these are again the carnitine cycle defect. In our metabolic clinic in Sabah Hospital, we have registered 8 cases of primary carnitine deficiency throughout the years. We have 7 cases of CPT1. I've never had a translocase or a CPT2 at any time. We have VLCAD 54 cases registered. The LCHAD are 10 cases, and the MCAD are 3 cases. So a total of 82 registered cases in our clinic. I'm not going to say they are all active. Some of them died. Some of them we have transferred to their hospitals when the other hospitals started to have metabolic specialists. Okay, now let's look at the diagnosis. You know that newborn screening is available, so this is not, I'm not talking about this. Newborn screening picks up the cases now. We are very happy about this. But look at what biochemical abnormalities can appear in children. Now, when they are sick, we can have this. We can have a hypoglycemia with no or low ketones. The CPK will be elevated. The ALT will be elevated. There could be metabolic acidosis. Now, the ammonia is elevated in severe decompensation. But I want to tell you that these can be normal when they are well. So when patients come to us for the clinic follow-up, I want them to have normal, everything should be normal. They shouldn't have an elevated CPK and ALT and so on. This should be normal. All can be normal when well. And if they come with a high CPK, then they have not been well and there is a lack of maybe adherence to management, and we ask what's wrong with you. They can tell us, oh, I had runny nose 1 week ago. So, okay, that explains the elevated CPK. Okay, now when we do to diagnose, you need to look at the specific acyl carnitines in the tandem mass, MS, through the filter paper, and the urine organic acid will show relevant dicarboxylic acidurias. We have to do the carnitine level. In primary carnitine deficiency, the carnitine level will be very low, but also when we are following our patients, there will be a secondary carnitine deficiency. And if we find secondary carnitine deficiency, we need to supplement with carnitine until the carnitine normalize. Now, I'm very sad to say that we do not have, we do not have we do not have carnitine measurements now, and we ask our patients to go and and try to find a private lab to do the carnitine levels, because we need to supplement or stop the supplementation for our patients when they don't need it. And of course, genetic testing will be done to confirm the diagnosis. Now, you know that, all that. This is the filter paper that is being done. Now, many fatty acid oxidation defects will have specific acyl carnitine profiles that will allow identification. I just want to show you this. So maybe now, do you know what this is? Not what disorder, what long chain disorder is this?
18 or 16?
The C14, the 16. ها؟ انتوا تعرفوها، دكتور ايمن طبعا هيعرف. اوعى تقول.
لا اعملها
ها قولوا، هسيبكم تقولوا، لا قولوا هتعرفوا دلوقتي. لو بص لما تقولوا ما ادري انا هفرح، عشان بعد شويه when you know I'll be very happy that you learned this from me. خلاص ما تدرون اسكتي. عبد العزيز اخبارك ايه؟ تحب تقول حاجه؟ ها؟ اخص عليك. طيب اوكي، لا this is طب خلاص كويس very good. اوكي let's good. الحمد لله. معلش يلا this is VLCAD.
أنا 18.
اوكي لا استنوا بس. let's go back to this. Let's have this is the VLCAD and this is a C18 with the things that come with it. So when you have here, you will have what? You will have acyl carnitines high, and they will be the C14s, 16s, the 18s, right? And the free carnitine could be low or normal low, because they could, they combine and form acyl carnitines, and so our carnitine, we get a secondary carnitine deficiency because of this. The acyl
breaking down to get
they are not breaking them. بالظبط. The carnitine gets combined with the acyl CoAs, forming acyl carnitines, which are high, and therefore the carnitine is low. And this would be the secondary carnitine deficiency, right? So you got that? You understand? تمام. الحمد لله. So this is it again عشان بس تبقوا انتوا شايفين C14 16 18 and so on. Okay, now let me show you something else. Now when you have an LSHAD, LSHAD is an hydroxy long chain hydroxy acyl CoA dehydrogenase, and this is it. I will show it to you here. Let me go back, معلش. So here the free carnitine as well will be low because of a secondary carnitine deficiency, but the C16 and the 18, remember, let's look at the OHs. This will have OHs, C16 OH, C18 OH, not really a C14. So let's go back and نشوف دي. So when you have OHs, so the first thing you need to do when you have long chain, find where there are OHs or not. If there are OHs, this is LSHAD, no OHs, and there are C14, this is the VLCADs. Get it? Let me go back. اللي انتوا غلطتوا فيها دي كلكم ما عدا الدكتور أيمن. No OHs here. So this is why we said this is VLCAD, right? تمام. Okay. ما فيش OHs هنا. لكن لما نيجي نتكلم على الثانية اللي هي ال LSHAD, now the LSHAD is OHs, right? And no C14s, LSHADs. يعني nice. When I understood all this,
يعني
I-
very fatty acid يكون ما فيها OH ويكون C18 high.
this C18, 16, the long,
Yeah.
the long ones,
14
and the
16,
OHs.
15.
Maybe you can, by the way, what if it's عشان بس ممكن تكون medium
This is
chain?
a long chain.
Yeah, احنا we're talking about the
Because OHs maybe
Right.
it will be C5 OH.
excellent. ممكن تكون من ام شاد او
Yes.
اتش شاد هيبقى دول او اتشز right. The same thing will apply to the medium.
ما OH.
Okay, عشان بس ما
لازم
نتلخبط.
الدكتورة دينا عم تلبس long see the long chain بعدين في OHs
صح.
عشان تفرق.
Right? Now let's have a CPT1. Now the CPT1 will show what? First of all, it will not combine with carnitine, and therefore the carnitine is very high. The free carnitine is very high. It doesn't combine. And the other thing, it doesn't form acyl carnitines, ما فيش acyl. So therefore the acyl carnitines are low and the free carnitine are high. And this is really the only metabolic condition where the free carnitine is high. And if you want to look at these are the abnormalities in each of the conditions. You have the presentation and you can look at it later on. Okay. So now we've done that, and let's go to treatment, and there are updates. First of all, let me tell you, because you need to know that the treatment is to avoid fasting. We can never allow the child to fast. This will be a very tragedy here. When you fast, what will happen? You will do what? You will produce lipid breakdown. Okay, because of the fasting, lipid breakdown will go and thinking that it can produce beta oxidation in the tissues, and in the liver it can't. It will go and find the deficiency, and there will be toxic acyl carnitine, and there will be no energy production anyway. So we cannot allow them to fast in neonates and young children. We have to feed them frequently, but above the age of 12 months, they can take feeds every 4 hours at daytime, and they can sleep well at night. So fasting overnight is safe in most patients with maximum hour from 8 till 10. This is recommended by most guidelines. But this is when the child is well. This is what they tell. But when the child is not well, vomiting, sick, having runny nose, the mother have to feed him every 2 hours. Shorter feeding interval during intercurrent illness or vomiting. We ask them not to fast, as I said, frequent feeding. Calories are adequate as any normal child. Carbohydrate 60%, protein 15%. I do say this. And we have to restrict the long chain fat. Now, this is a special formula called monogen. It contains normal proteins, normal carbs, but the fats here are not decreased in mostly medium chain. Medium chain has to be given, except if the condition is medium chain MCAD. And we always calculate that they should take 30% of fats. 30% of total daily calorie. It is just as if he's taking long chain, but we're not giving him long chain, we're giving him medium chain. And we need to give them 30% to secure 30% of intake. If the patient is, we need to give essential fats. These are the omegas. Why? This is supplementation. The essential fats are in long chains, which we are not, and we are not giving long chain. So, but we have to supplement by essential fats. So we give them essential fat. We have a special powder for this. Now, if the patient is young and getting hypoglycemia, we will give him an overnight tube feeding through a pump, and we tell the mother care during illness and vomiting, and we give her a sick day protocol. I will tell you about this in the, I think, in the next slide, or the slide later on. Now, what about carnitine? Is carnitine important for
So,
long chain fat?
can I just like just one
Arga?
before we regarding this? Let's say if you have a child family history, okay, because this will sometimes we are facing.
Yes,
What is your recommendation for
but
this
Didi,
about stop?
لا,
There is a family history of VLCAD.
and until I
and
get the diagnosis,
no,
and
no, no diagnosis.
ah,
She's still, she didn't deliver. So
yeah,
sometimes in maternity, they are taking some precautions,
so,
like not to harm the, so they will
yes,
start monitoring.
yes. Well, this is what I used to do even before newborn screening. I tell the mother, you take monogen milk, and I write something for the obs and gynae and the neonatologist, and I told them that as soon as this, before even newborn screening. يعني maybe remember ما اعرفش اذا كنت تعرف اذا كان عندنا كان الدكتور محمد عبد الحميد. Yeah, so I was doing a tandem mass with him. So what I tell the mother, you put the patient on monogen, and you will come to me first of all. We will do the filter paper and put the patient on monogen, and I send this with the family to doctor in the pharmacy, the faculty of pharmacy, and so on. And he remains on monogen until the result comes. If the result is not equivocal, we stop monogen, and we for a few days and do it again.
المونوجين ما في فاتس.
لا في فاتس في medium
كم في
chain
كتير.
تقريبا 90% are MCT.
انا ليش انا عم بحكي انه كدايجنوستيك احنا لما بنيجي بدنا نعمل التحليل اذا كان هو البيبي انه فور ذا نيو بورن وما عم بياخذ اي مش انه بريست فيد مش عم بياخذ
ما
اي
هو
حاجه الريزلت sometimes it comes like equivocal.
هم بيحبوا انا عارفه في النيوبورن سكريننج بروجرام هنا بيحبوا to do it the next day بعد ما يدوا فيد. انا بيقولوا لي
اوكي
كده
بس احنا بنحكي للفاميلي هيستوري. اوكي
you know, so it's up to them. You want to do it the next day, you want to give them a feed بيسموها challenge, but sometime I want to say something. يعني this patient has gone through labor and the stress of labor. There will be some acyl carnitines at يعني you get it, but anyway, if you don't find it and you want to challenge the baby later on, there are lots of things that you can do. This baby won't get lost anyway.
احنا بس انا just what I want just like for the
Yes.
don't in the lab because this is our work in diagnostics, like don't look very specific for the numbers. When you have a number like I have C14 value, I have a cutoff. So the cutoff is by itself sometimes due to like restriction, they are not giving, or this one sometimes is not very elevated, which we are expecting in VLCAD. Maybe it's sometimes very good.
Yes.
And the ratios will be helpful in that condition.
So.
And we, of course, we communication with the metabolic specialist. They will tell us about what is the condition, if the baby on monogen, if there is a restriction. So it's not like easy for families.
Instead of النسبة يعني it's no, we have to consider it, right?
Yeah, we need to go through all this. We need to know.
And you, this is it, the clinical situation. Is he on monogen? And that's why maybe you can stop monogen and give him a feed and see. Sometimes even at birth, wallahi, the acyl carnitines are positive, this from the stress of delivery and so on. But if it isn't and we're still not sure, we can stop the monogen, give him a feed and do it again and so on.
At least he will be under
I do
supervision.
also, and I do a CPK بصراحة also, because sometimes I do find the CPK at that point. So this gives me again, I know that what I'm dealing with something VLCAD or something like that. Now, are we going to give carnitine in this long chain? There is no evidence to begin L-carnitine in newborns at all. We don't begin at that point, but we do know that the carnitine level will decrease in any decompensation. You remember, it gets mixed with the acyl, combined to form acyl carnitine, and then therefore this is carnitine deficiency. But it does normalize over the next 2 to 4 weeks without supplementation. However, during follow-up, we need to do a free carnitine, and if it is low, within 1 month after a previous decompensation, really I supplement with a small amount, and then I have to do it again after 6 months. The only condition where carnitine is definitely very important, unequivocally, there's unequivocal evidence, is when you have a carnitine transporter defect, right? You need to give carnitine. Now what, oops, exercise is spelled wrong. Pre-exercise MCT, yeah, we give pre-exercise MCT. Now remember, this muscle now is going to work during exercise, and it needs more MCT fat. Normal people will derive the fat from their fat stores. This child, if he gets his fat from his stores, he will not get beneficial fat. So we give him pre-exercise MCT before each exercise, with or without a carb. We tell the mother this, please give him this amount of MCT, some juice every time you see him going to exercise, whether at home or at school. Do we restrain him from exercise? No, he can exercise according to his tolerance. These are points which we say. Now, during home and you are sick, is it okay if I just take another 10 minutes or so? عشان time. Okay, now this is the sick day home management. We tell the mother when your child is sick, what are you going to do when the child is sick? We give them حاجة اسمها glucose polymer, VitaJoule, MaxiJoule. We tell her take this glucose polymer every 2 hours. We give her we ask her to do a 10% solution from this glucose polymer. This 10% glucose solution given every 2 hours, remember glucose will produce insulin from our body. And insulin is an anabolic hormone. It will stop the catabolic process. What I'm doing here, I'm not giving her calories. I'm giving her something to stop the catabolic process. Glucose, 10% solution every 2 hours will stop the catabolic process during a child who's having runny nose or gastroenteritis or so on. Give antipyretic. Make sure that you're going to give this every 2 hours. Careful if the child is having nausea or vomiting, and look why is this child developed this event. If he's sick, of course, you're going to take him to the doctor as well. Now remember, if vomiting, if he is refusing to take this glucose polymer, if he is not getting better within 1 day, lethargic, or parents are concerned, come. Because what we're going to do in hospital is we are still going to give him a 10% glucose. It is 10%, 10% here, 10% here, but this time it's an IV. I'm giving it and glucose infusion 10% at a high rate of fluid rate, and this is to stop the catabolic process. And I'll find out why he's sick, and I'm treating the trigger. And parents have to be given an acute illness emergency management protocol. So these are the emergency protocols that we have done for our patients: VLCAD, LCHAD, primary carnitine deficiency, the CPT1 and the MCAD. These are really lifesavers. When the patients have them, they take them, and it's 1 page, by the way, and they take them to the ER, and the ER doctor will just follow what's in the square down here, and manage the patient in the emergency, even through admission. It's really help. These are lifesavers. Okay, when they are admitted, we have to ask ourselves, first of all, in the ER, is this patient coming with hypoglycemia or not? Remember, hypoglycemia can happen. Maybe not, but it can happen. If it is so, they are going to give a bolus glucose. Now, even if there is no hypoglycemia, you are going to put a high IV glucose infusion at high rate. This is a 10% dextrose running at 1.5 maintenance fluid rate. If the CPK is very high, this is a huge or a very massive decompensation, I need to put him in the ICU, put a central line, and go more, even 15% dextrose, and give insulin. I need to give insulin, not because the glucose is high, but because I want to give insulin to stop the catabolic process. This is what we do in the ICU. Remember, never to give lipids in long chain fats. You don't give a carnitine really unless it's carnitine transporter defect, the first enzyme problem. Correct the triggering event. Always monitor the CPK. By the way, many times we get the CPK normal on admission, and we feel that the child, he doesn't have a decompensation, and next day the CPK is shooting up. And always evaluate for an evolving cardiomyopathy, right? Okay, now anything new in the management? Let me tell you about this. Everybody knows about this, so you should. Now, there's something called triheptanone. You heard about it? Triheptanone has been FDA approved in 2020, and since then we have articles talking about it. By the way, when we went for conferences all the time, starting from 2014, we have always been listening to lectures or talks in conferences about triheptanone under research work, and I never understood what triheptanone was, and we were waiting for this treatment for long chain fat, and then suddenly we were happy that it's finally has approved, and now we understand more about what this is. Let us now go to this slide. More simplified, I had to do it this way. Remember, these are the CPTs and the carnitines, and we now have the acyl-CoA here. We have the long chain spiral here, producing NADH, FADH, right? And then producing acetyl-CoA, which goes to Krebs cycle, and the Krebs cycle will produce more NADH, FADH2 for the ATP. Okay, and now we are, okay, we have, because of the block here, we are now giving MCT. MCT is C8 or C10. And when we give MCT, we know we don't need the carnitine cycle. We just can go in immediately. And immediately it will find the medium chain and the short chain enzymes, and it will form acetyl-CoA, and we will have everything perfect. And as much as we give MCT, as much as we're going to get ATP, right? Everything is wow. But why are we still not doing well? Why are still patients, if everything is perfect and we're giving MCT and bypassing the block and
Maybe because it's
why are still patients getting admitted with decompensation? They are not yet, and they have cardiomyopathy still, and they're adherent to the MCT. So why?
infection or something.
Yeah, but they should now be normal, زي normal individuals.
It's more cyclo-A من الحتى بالقديمة maybe build up.
ما هو we can give as much as we want. Give MCT as much as you want. You will have more acyl-CoA. You will have more. But why are we not doing? Why are we still not doing well? What are we missing in the management? Okay, well, triheptanone made us a bit understand more. So triheptanone is C7 MCT. C7. Now remember, these are C8 and C10. These are all even chain carbon. So each molecule will give two until it finishes, right? Now this is MCT, which is a C7. So what does it do? هنشوف دلوقتي. So it goes inside عادي, and it's going to be broken down by the medium and short chain enzyme, but it's going to give what? The C7 will give 2 و2 and then 3. مش 2 1 3 لازقين في بعض. Now these three, okay, so every 2 acetyl-CoA every molecule will give 2 acetyl-CoA, and then we are left with 3 carbons combined together. What are these? These are C3, and we all know that C3 is propionyl-CoA. Now propionyl-CoA will go and feed Krebs cycle and produce succinyl-CoA. Now Krebs cycle in the fatty acid oxidation defect is impaired. It doesn't work because it doesn't have substrates. And by giving substrates from another direction, you get the Krebs cycle to work. And this resupplies Krebs cycle intermediates, or a process called anaplerosis, and this helps in maintaining gluconeogenesis and in maintaining the health of Krebs cycle. So it's a better MCT than the usual MCT. It is still MCT, but it is better because it gives supplies to Krebs cycle as well, making it work, because it wasn't working properly even when we are trying to do the MCT. So now it's an FDA approved treatment for use as a source for calories and fatty acids for the treatment of pediatric and adult patients with molecularly confirmed long chain fatty acid oxidation defect. Okay. So this is.
So I will start with the
Uh-huh.
triheptanine immediately,
Yeah.
or you'll give MCT diet first?
I will tell you about
Okay.
this. So now this is with the Zazahe bottle. It's expensive as well. Yeah, everything is expensive. It's called Dejolvi. It is the first and only FDA approved treatment for patients with long chain, approved in 2020, June 2020. Now, what does it, during the research, it did improve the cardiac effect more than MCT, compared to MCT, improved the left ventricular ejection fraction, lower heart rate for the same work performed when they looked at the MCT group and the triheptanine group. It eliminated the hypoglycemic event. It reduced the rate and duration of major clinical events. Major clinical events are the encephalopathy, cardiomyopathy. So it reduced, and I have a slide for this. Look at this, I found it interesting. These are the reduced rate and duration of major clinical events. Clinical events are the cardiomyopathy, the hypoglycemia, the rhabdomyolysis. And here are 29 patients who were in the study. Let us take this patient. This is one patient. Before using triheptanine, he had all these admissions with these events. After using it, he was only admitted twice. Now, this one, I didn't have anything, but he had one here. And here was better. And here, there are no admissions at all. The ones up here are the young children. The young children have more admissions than the older one. But even so, the admissions or the events are even better. They are less than before. So you can see there is improvement, and that's how they are selling it. Now, the most common problems are GI. diarrhea, vomiting, abdominal pain, and we can try to manipulate the dose into giving smaller, more frequent doses and so on. In this study, some patients stopped taking the Dojolvi because of the GI upset, so they stopped it and didn't want it. But those who went and continued, they are on it. Now in the metabolic clinic, we have now more than 1.5 year experience with triheptanone, because we have two brothers who are you started using this medication because we sent them actually to USA at that time, wanting them to start it there, and they returned on it, and we are continuing on it. And when they were there, all this time when they were in USA, we had Zoom contact with the doctors there, and we knew exactly what was happening and how they started it and so on. So we had the experience actually starting from when they were in USA, and now they are here with us. Now we have also started one female patient with LCHAD, aged 21 years, and one male patient with CPT1, age 18 years. And we started it in January 2024. Okay. I will now just give you two quick cases, and you will love them, so I have to do them, sorry. It's okay, huh? هتنبسط.
أنا صراحة أنا مع.
Yeah. مش
Really,
كبار.
you are going to get this such nice presentation. But Dr. Dina, regarding this triheptanone, because now I'm a little bit weird for our side.
Yeah.
If it's going, the C7 is going to break down and coming to propional carnitine. If I'm going to do the tandem,
ما أظنش هتحصل حاجة. I don't
it
think.
will not be elevated.
I don't
unless,
think
like,
so. But
because I never had.
But why not take our patients and
when you have any patient, just try
but we
to
have.
work.
I have the two boys. We
Because
can send.
sometimes we are getting such a results, and now I'm starting retrieving like C3 can be elevated but not significantly high. There
Okay.
is nothing any about methylmalonic or propionic acid.
Okay, I will. Yeah, why not? Our two patients, these two boys, I can send you an acyl.
When you send it, at least
I will tell
we
you.
can check if it's going to have any misleading. Because when you give the MCT diet, when it's on MCT diet on organic acid, we can see also
صح.
there is panels for MCT diet.
Let's find out.
Yeah, we don't say we don't say that this is abnormalities. We know that this is the doctors, they are giving MCT. That's why it's giving this picture. Some dicarboxylic.
Yeah, let's find out. Let's find out. By the way, I just missed saying when I'm talking about the diagnosis, when I'm looking at patients, what is the monitoring parameters for patients with long chain fats or so, I find that still acyl carnitines, tandem mass, the dried blood spot acyl carnitine are part of the monitoring. But why? Because outside properly, they do it quantitative.
Yeah.
So they can look at the numbers. I also, part of follow-up is do CPK, acyl carnitine, right?
See, there is improvement.
Yeah.
It's going down.
But we don't have this.
Why?
ليه ما عندناش quantitative acyl
Like
carnitine?
carnitines?
I can do it
Let's
every
say-
follow-up,
Yeah, you can do it anytime.
and you will give me some.
I can give you anything.
حلو.
Just ask Dr. Dina.
I just ask. Okay. Halas, I will put it. Thank you very much. Okay. Now let me tell you cases, show you two cases. And this is Nesma. Nesma this is her story. It's one slide. Nesma had two life-threatening Rye-like events. Rye-like events is the hepatic encephalopathy with the patients with hepatic coma, hyperammonemia, hypoglycemia, elevated ALT, and so on. She had events in Mubarak Hospital at the age of 1 year, and then another one at the age of 2 years, and this was not explained. And then at the age of 3 years, her family took her to Umrah. And once she landed in Umrah in Mecca, she developed gastroenteritis and went into the ICU. And in the ICU, she had a severe hepatic encephalopathy with hypoglycemia, hyperammonemia. And I have the referral letter later on from the ICU there, saying, written that this is it seems to be a metabolic condition. Please take her to a metabolic specialist once you go back home. Now, what happened is that this patient went back to Mubarak Hospital, and because we were the only metabolic clinic since 1995, this patient came to me. So she returned to Kuwait with the above history, and she was referred to Sabah Hospital Metabolic Clinic. And this was and I sent for her a filter paper for tandem mass in Saudi Arabia. You may not know that. Maybe I can tell you this history. بصراحة, I had the slide, but I didn't put it. By the way, do you know when was the first tandem mass that serviced in Kuwait? Dr. Ayman, I'm sure you know. Actually in 1990, in early 1999, we had the privilege of two important doctors coming here to Kuwait to give talks to the faculty of medicine. And also it's a general talks, yani everybody, every medical doctor can attend. So I was informed by Dr. Sadi Alawadi, who was head of genetics. She told me, Dr. Dina, I have 3 doctors coming to give talks at night, but I don't want them in the morning. Please take them. So I told her, what doctor? She told me Dr. Wraith. This is a doctor from Manchester.
Yeah.
Dr. J.V. Leonard, a very famous name from Great Ormond Street Hospital, and Professor Ozand from Saudi Arabia. So I told her they are coming here. Very famous name. Publications are from them at that time. So Professor Ozand is the one who established the metabolic service in Saudi Arabia, in King Faisal Hospital. He's the father of metabolic service in King Faisal Hospital, and I know him from his publications, but of course I never saw him. Professor Leonard is the one who was, when we send patient to Great Ormond Street, we will have his reports coming back and the publications, and Wraith is somewhat we knew from Manchester. Well, actually, yes, I was very lucky. I attended their talks, and I want to tell you that Professor Ozand, for the first time in front of everybody, was talking to us about the tandem mass and showing us results. You put the sample, and within 7 hours you get a diagnosis. And we will say, oh my God, we're going now to diagnose all our patients. We never heard about the tandem mass except from him. And he said he's going to start using it for as newborn screening in Saudi Arabia. We can put many samples, and so on, so on, so I was really, everybody was wow. Now everything is going to be very easy. And he talked about tandem mass. This introduced us to tandem mass and his results. Professor Leonard talked about hypoglycemia and urea cycle. Ray talked to us about lysosomal storage disorder. So, and of course, I had the privilege of them coming to me for 3 days in the morning, where I presented for them cases and brought cases for them. And of course, we exchanged our emails, and I did send them emails, and I made use of them very much because they taught me a lot, and they were really very صراحة يعني very يعني I cannot say how wonderful they were. I will just tell you about Professor Ozand. I once had the problem with the glycogen storage disease. Maybe my first 2 patients, and I wrote him one question and asked him what to do. What do you think I should do for so? And you know what? Professor Ozand sent me an email, which when I printed it out, it made 3 pages. And I want to tell you, it is not a copy paste because it was full of grammar mistakes and spellings. It is somebody who was writing, telling me, don't worry, do this. And if you find this, you will do this. And I was saying, oh, what this man really, he has, he is, and he taught me everything in these 3 pages. I made a printout and I put it in the file, and I learned from him. Okay, now what I did, in early 90, as soon as I met them, I emailed Professor Ozand, and I told him, Professor Ozand, your lecture on the tandem mass was wonderful, and I was wondering whether you can help us with the service by tandem mass. Can I send you filter paper when I don't know the diagnosis and you'll help me? Immediately he answered back. He gave me the email of Professor Dr. Muhammad Rashid, who is the head of the hormone of his lab, metabolic lab in Saudi Arabia. And Dr. Muhammad Rashid communicated with me and told me we will be happy to do tandem mass for Kuwait, for your clinic, for 1 year free of charge. Any number. You just send us the sample and we'll do it free of charge for 1 year. So you have to ask when you have to ask when you. So I asked, and I got this result. And he said, okay, but after 1 year, it will have to be by payment. So I went and talked to Dr. Rao, and I told him I want now to send samples. He said, okay, send. We will. Sorry. عارفين دكتور راو؟ Okay, so we had the logistic. We were able to send because there was a logistic of sending a sample abroad for 10 kds. So what I have to do is just to take a sample for any patient I want, send it to Dr. Rao, and Dr. Rao will send it to King Faisal. 1 year free of charge, and the Dr. Muhammad Rashid sent me a box full of filter paper. And I thought wow, everything is working. And I want to tell you, then Nesma came. And Nesma came, and she was the first patient. I said that I will come first. When I saw her, I read the report from Mecca, and I know that she had a metabolic encephalopathy. I put a blood spot on her immediately and sent it. And next day, or maybe next 2 days later, Dr. Mohammed Rashid emailed me. He told me, Dr. Dina, your patient has carnitine 0. And this is primary carnitine deficiency. Dr. Dina, this is a life-threatening condition. However, it is very helpful, very encouraging when you give her carnitine for life, and she will not have a decompensation. Again, you just saved her life. This is what is in his email. So I called the patient after 3 days and I put her on carnitine. Nisma, this is her at the age of 7 years. And I want to tell you that she's Egyptian and she wanted to become a doctor, but she didn't get the grades to go to medical school. She had the grades to go to faculty of pharmacy, and because she wanted to become a metabolic specialist, and she became a pharmacist. And she's working in Egypt. Her parents work here, so every winter time she comes to me and say hello. So I see her still, but she's
surviving on
carnitine. She can never stop carnitine. That's nothing. Live her life normal, but she has to be supplemented with carnitine. She was the first patient I sent a filter paper for. Now treatment is carnitine and no further episodes. Normal child, normal adult having a normal life, alhamdulillah. So this is a case. And the final case is interesting as well. This is Shahd. She was admitted to Sabah Hospital in 2001. Now this is the history. Now on day 1 at 9:30 at home, she was previously healthy, but when the parents went to arouse her, she was unarousable. She was not arousable. So they carried her to our ER. She reached our ER at 10 a.m. in Sabah Hospital. In the ER, she was unresponsive, and when they checked the glucose, it was 1.1. So they gave her a bolus infusion, a bolus 10% and infusion, and kept the infusion going on. And the blood glucose improved to 2.6 and reached 14.5. Now, at that time, we had our admissions according to turn. And on that day, I was doing a round, and Dr. Ibrahim was the senior, I was the consultant, Dr. Ibrahim was the senior registrar, and we were doing a round. So the ER phoned us and told us we have a patient who was having hypoglycemia and now for admission, and we are sending her up. So Dr. Ibrahim told me, she's comatose, send her to ICU. I told him, no, let her come here, let's see her first. She arrived to our ward at 10:30. I took the history myself quickly. Normal child. She's a normal child. She had her dinner at 8 p.m., right? Which was a small meal, and she had runny nose for 2 days. And she slept after this until 9:30. See how long she slept? And the family, the parents are cousins with 4 healthy siblings, as the parents told me. When I examined her, she was comatose, but responsive to painful stimuli. Her liver was 5 centimeters, and I couldn't see anything abnormal otherwise in the girl. So what I did is this. I asked the parents, I checked the blood sugar, and I found it was 4.5. Now remember 4.5 now, but previously it was 1.1. And I asked the parents, did she pass urine in the bed or on the way to, and they told me no. So I asked Dr. Ibrahim to catheterize the urine, to check the urine at bedside. And when we checked the urine at beds, it was negative. I phoned Dr. Rao and told him this is a very important case. I'm taking all the critical sample and please process and don't lose any sample. So he told me, send me the sample before 12 noon, and we sent all the samples that were in the lab before 12 noon. Okay, so now let's have a look at the results. But before we look at the result, over the next 7 hours, she had normal blood sugar on the drip, and she was semi-comatose, but improving. And I was, phoning the sisters to find out about her. And by evening, the sisters told me she's sitting up. She had a snack, and she's having the blood sugar is stable on a glucose GIR of 4 milligram per kg per minute, which is the drip that we have put her on. Next day, she was back to her normal self. She was eating well, and we discontinued IV, and we had a diagnosis on day 5 and discharged her. Let me show you. Now, let me show you. Okay, now this is the result of the critical sample. Okay, now the blood sugar at that time was 4.5, but remember it was 1.1. So maybe we can have metabolites and hormones that can help us. Okay, now the electrolytes were normal, the ALT was normal. Look at the BGA. Metabolic acidosis, right? Now the ammonia was high when we got it, and we repeated it later on, and it was normal, so we didn't repeat again. Lactate was 2.5, the amino acids later came normal, and later on the lactate pyruvate ratio is normal. Now, this is not the problem. Now, let's have a look at here. Look, this is the free fatty acids. Anybody, what do you think? Very high. Abnormal or not abnormal? Abnormal? Fine. Anybody has another point of view? Are these very free fatty acids very abnormal?
Normal range.
What are they now? Are you happy? Are you sad or happy with this free fatty acid level?
كانت hypoglycemic,
Uh,
right? Fatty acids, يعني they are
Yes.
trying to
Yes, I'm happy. I'm happy that the free fatty acids are high. Right?
They are
They're normal.
compensate,
Yes, they are high because of the lipolysis. Remember, when you are fasting and you're normal, and when you're fasting, you get high free fatty acids because of the lipolysis. I'm happy about this. Now, what I'm expecting after this is that these free fatty acids should form ketones.
Yeah.
Did they form ketones?
No. Uric ketones negative.
And look at the 3-hydroxybutyrate. We send the 3-hydroxybutyrate acetoacetate in the
Very-
blood. Very low, right? So this high free fatty acid did not produce ketones. Now look at the cortisol. Does she have Cushing? Or this is acceptable and desirable? Desirable. I want to see a high cortisol, right? Because this is
stress.
the counter-regulatory hormone. This is it's working, right? I'm happy. Okay, now you can see now this is a hypoglycemia that happened, which is non-ketotic or hypoketotic. Okay, now let me show you again more information. This is the acyl carnitine result. What does it show? C8, C6, C10, medium chain. And let me show you the urine that came. These are the urine. Some things here. Sobaric, sobacic, adipic, hexanyl glycine. All the time when I was having patients with VLCAD and L-shadow, and I know that the MCAD are very common in the Western countries, and I was saying, where are the MCADs of Kuwait? Does Kuwait have any MCADs or not? Where are the MCADs? And I want to tell you, this is the first MCAD patient from Kuwait. This is the first time I see an MCAD. Okay, now let's understand this. Now remember this. Now these are the enzymes of C10, 8, and 6. And when you have a block in this enzyme, you get you get C8, C10, hexanyl carnitine is a C6, octanyl carnitine is a C8, and you get sebacic from the 10 and suberic and adipic, and this will appear in the urine. Hexanyl glycine is here and so on. So these are the metabolites that occur when you have an MCAD deficiency, those that are in the blood and in the urine. And I was very happy to have this girl, really. Immediately on day 5, we told the parents the diagnosis. We told the parents never to fast, never have this scenario happening again with your child. Particular care when she is ill, she has to be fed and woken up to be fed. We gave her a dietary emergency protocol so that during illness she should take the Maxijul and the Polycos and take a diet high in carbs. Any vomiting, come for admission. We gave her an MCAD protocol paper. I tested the SIBs and they were normal. And during follow-up, she continued to be well, and she had 1 episode of decompensation as an adult. I want to tell you that 25% of MCAD patients die during their first presentation. 25% die during the first presentation, unidentified, and they would be picked up on forensic examination. And this was the protocol I did for her as an MCAD emergency protocol. And I upgraded it a little bit later on through the years. And we published the case, hypoglycemic coma in a young girl, first case of MCAD deficiency identified in Kuwait. The publication was in 2005. So I did it. خلصنا الحمد لله. We went through the energy production and fatty acid oxidation. We talked about the fatty acid oxidation cycle. We went in to look at the disorders. You now know why they cause illness. You saw the clinical phenotypes. We talked about diagnosis, treatment, and triheptanone. The 2 examples I gave you, remember, one was important for what? One was the first primary carnitine deficiency identified, and the other was the first MCAD deficiency identified. And maybe next time, maybe I can tell you about our patients on triheptanone. So we do know that fatty acid oxidation defects are among the commonest inborn errors of metabolism. The VLCADs are the commonest long-chain fatty acid oxidation worldwide. And in long-chain fatty acid oxidation defect, mortality is high. early onset disease, as we have all of the patients are early onset disease. They will be having the least favorable life prognosis. Constant risk of metabolic decompensation during periods of prolonged fasting and stress. Fasting is prohibited. MCT oil has to be given. It's a crucial energy source in this condition. They can't have an energy source for fat apart from the medium chains. Triheptanone is an MCT with C7 carbon. It's approved in 2020 as treatment for pediatric and adult patients with confirmed long chain fatty acid oxidation defect. They improve the cardiac, the hypoglycemia, the admission rates, better endurance and quality of life. And thank you for listening.
Thank you.
Thank you for very
الحمد لله الحمد لله. أنا عطلتكم نص ساعة أنا عارفة بس معلش.
rarely لما بتشوف هيك مثل conditions يعني metabolic.
By the way, we want to thank the lab. We cannot work without the lab. The lab are we are always asking you